Hello, everybody. Welcome to the Ophthalmology Times Retina series. I'm Carl Regillo. I'm the director of the Retina Service at Wills Eye Hospital and professor of ophthalmology at Thomas Jefferson University. And today we'll be talking the port delivery system. And it's my distinct pleasure to have my very good friend and colleague in practice with me at Mid Atlantic Retina, Dr. Jason Hsu here. Jason is a professor of ophthalmology at Thomas Jefferson, is on the retina service at Wills Eye with me. It's a pleasure to have you here, Jason. Thanks for joining.
Thanks so much, Carl. It's great to be here.
By way of background, I think everyone is now familiar with the port delivery system and the fact that it's FDA approved for three different indications: wet AMD, DME, and diabetic retinopathy. It is the first and only sustained delivery approach we have in retina to treat these conditions or frankly anything. And it's been on the market now a few years, although there was a temporary pause, but it's now back in our hands. And it's still in clinical trials too, testing the product in various ways. So, Jason, you were part of the clinical trials. You're very familiar with the data. You know the space very well. You're a major contributor to the research and advancements in our field. So tell me, what do you see as the port delivery system in terms of its ability to control disease in our patients with these conditions?
So there's really no question that the port delivery system is a unique sustained delivery platform that really has the potential and has demonstrated the ability to control all those disease states, as you mentioned, between the wet AMD, the diabetic macular edema, and the severity of diabetic retinopathy. So I've been very impressed from day one of the program. We were involved in both the phase 2 ladder trial and the phase 3 in all the different disease states. So Archway, Pagoda for DME, and Pavilion for diabetic retinopathy. And certainly looking at some of my patients who had the port placed, it was very impressive. I think in ladder, I remember seeing one patient that I think went 18 months without a refill, even though that's off label now. But 18 months without need for any rescue therapy and was doing amazing and was happy as a clam. So we know that this device has great potential.
Yeah, I'm glad you mentioned that because as the way it was tested at the phase 3 level, we were refilling the device per protocol every 6 months and found that it controlled disease very well. Very few patients needed supplementation or rescue of any type. In fact, less than 5% over every 6 month cycle needed anything more than the port to adequately control wet AMD, DME, and every 9 months, actually, for the Pavilion diabetic retinopathy without DME study. Uh, you're
Right.
right. And I think everyone's impression is that it works really, really well. It is true sustained delivery and it gets us a minimum of 6 months. And as you mentioned, the potential to be even quite a bit longer. We can't predict how long, but it could basically be 9, 12 months or so in select patients with any of these disease states. Um, so in practice, though, we're not seeing a lot of utilization. And why do you think that is?
I think that's multiple reasons for that. I mean, honestly, I think part of it is that we have the second generation, anti-VEGF drugs and combination, angiopoietin 2 inhibition, and we're seeing some of those patients getting out to the 4 to 6 month range as well. So some people ask the question, well, if I can just do an injection every 4 to 6 months, do I need a permanent device implanted in my eye? I think there's some fears based on the original results of the Archway trial with a 1.6% endophthalmitis rate, just sort of giving people a pause about having this permanent device placed. And then looking to the future, I think we see things in the pipeline. For example, the tyrosine kinase inhibitors coming in through phase 3 is looking very promising as Q6 month delivery platforms as well. And then, I think that begs the question, do I need a surgical procedure? So I think it's really, there's a lot of different reasons that give people pause. Certainly from a patient perspective, I've certainly talked to a lot of my patients about the option of this. And a lot of them are like, well, I don't really mind the injections that much. Um, and even though I bring it up with patients that have more frequent need for injections, they still are a little hesitant to undergo a surgical procedure. Uh, so I think that's another hesitation.
Yeah, you're right. It's a trip to the OR. It is a device, and it has some unique adverse events associated with it, both surgically related, so therefore shortly thereafter the surgery, perioperatively, and even later on, you can get device exposure with conjunctival erosion, and that can lead to late endophthalmitis and rates of endophthalmitis, as you pointed to, which are in the 2 to 3x range compared to the control arms in the study. Um, and I'm sure you're aware, interestingly, the more recent diabetic retinopathy studies showed lower rates of endophthalmitis and less conjunctival issues. Why do you think that is?
Yeah, so I honestly think that it's related to age. I think that's part of it. I mean, part of it certainly could be that, we took the learnings from Archway and Ladder, and that helped to refine the techniques and the realization that, you need to be very meticulous about the conjunctival closure and a good tenons closure as well. So almost like a two-layer closure is the ideal sort of technique to use. And I think that's part of it. But again, we know that in younger patients, you're going to see thicker conjunctiva, easier to find the tenons, whereas in someone that's say 80, 90 years old, it's super, super thin. And so I think a lot of it, if you're going to do the port delivery system, is to really look at the patient selection is going to be really important. And thinking about maybe your younger AMD patients and certainly your diabetics as well, and just really inspecting the conjunctiva carefully, make sure there's not a lot of scarring and other issues. But yeah, I think that's part of why we saw that differential, because I think the mean age in Pagoda was maybe 60 years old. The mean age in Pavilion was even younger, like 50 years old, for those patients. So it's that younger age group. And you're absolutely right. There was like, I think maybe one endophthalmitis case in Pagoda and none in Pavilion. So it was very impressive results.
Yeah, you're right. I'm sure that is a factor. The health of the conjunctiva. Glad you brought that up. It should be assessed when you're considering a patient, regardless of age, and it could account for some of the uh, lower rates of these adverse events related to conjunctival exposure, erosion, and device exposure. Um, I agree with you, and I think, however, that it is the learnings as you mentioned too, because an analysis we recently did looking at um, before and after some refinements of the surgical procedure that took place even while the wet AMD studies were being conducted, we definitely saw a drop in the rate of conjunctival issues and endophthalmitis. And it's actually hovering now closer to about 1% when you look at all the implants, all the surgeries and implants done, regardless of disease state, after a major revision in the surgical protocol as of 2020. And I think we're continuing to learn. I'm actually convinced we can even do better. And there is some ongoing studies looking at some variations on the technique that could even bring those complication rates down even lower. But you're right. I think what holds it back is a combination of surgery, device, unique or increased adverse events compared to ongoing injections, and the prospect of some other sustained delivery approaches coming. You mentioned TKIs. Yeah, an injection that could give us 6 months of disease control, probably not across the board as well as port delivery system based on existing data, but we'll see. Phase 3 studies are currently underway with results within the next year. Gene therapy,
Right.
potentially even one and done, that's potentially attractive, but that's a few years away. And I don't really see any other anti-VEGF biologics. You mentioned the second generation. I'm glad you did because it's true, we're getting more durability out of those biologics than we did with the original ranibizumab and aflibercept. And that probably does take away from the durability, or I should say, the burden, unmet needs that we're trying to contend with. So there's a
Right.
lot of reasons. It's multifactorial. I totally agree with you that the device proof of concept, just sustained delivery, is a great way to control these diseases. Probably better than intermittent injections where you get maybe some disease fluctuation. because the
Hmm.
way I see sustained delivery is it's not only to reduce treatment burden, make it easier for patients, but safety net, provide disease control when patients can't make it in, they're in the hospital, they miss an appointment because of a snowstorm, you know how that is, and the prospect of better long-term vision outcomes. You, I'm sure, have seen the 5 and 7 year long-term um, uh, portal extension study outcomes. Do you want to comment on those?
Yeah, so I mean, again, it's very impressive that the visual acuity is maintained over long periods of time, and very few late complications were seen as well. So I think a lot of very promising data about the long-term safety and efficacy of that device in patients' eyes. And I just wanted to go back to what you're talking about with loss to follow-up. I mean, I think that's such a huge issue. That's been like a passion of mine in our group, and just sort of being one of the first groups to really raise that issue with intravitreal injections, the number of patients that just can't come back for various reasons, and this is a game changer. If we have something, and even though it has to be refilled, but potentially they could go much, much longer. And I like that idea that this is really kind of like a safety net for them in many ways.
Yeah, you were the leader. You are the leader in identifying the problems that can occur when patients don't follow up in a timely fashion to get their treatments for these disease states. Can be devastating. Diabetic retinopathy, you showed. Wet AMD, we saw that not only in studies, but during the COVID epidemic, when
Mhm.
patients couldn't get to the office, we saw patients lose vision because they missed their follow-up. So,
Yeah, one other thing, which I found very interesting is, I've been working on this post hoc analysis with the, Roche Genentech sponsor of the port delivery system. And, one thing that we found which was really interesting is when we look at the PAGODA patients who had bilateral diabetic macular edema, they could get the port delivery in one eye. The fellow eye could be treated whenever the investigator thought it was necessary. And what we are looking at is the differential in the severity of their retinopathy and the macular edema, macular thickness in those eyes, comparing the two. And you can see that the PDS eyes do very well. I mean, over half of the eyes have no intraretinal fluid at all at the end of 2 years. Twice as many have no leakage at all. Whereas in the fellow eyes that could get anti-VEGF whenever the investigator thought was necessary, they have much higher rates of leakage, thickening, intraretinal fluid that persists, worsening severity scores. So it really just underlies the fact that even though those patients were being monitored monthly, that we do tend to undertreat as physicians. And this port delivery system almost is a magic bullet in some ways that allows this prolonged benefit for patients, and we don't have to be thinking, okay, do I need to do another injection? Do I need to convince the patient that they need a treatment today, because it's already constant VEGF suppression.
yeah, that's a great point. I'm familiar with some of those data, and it's fascinating. Um, Sustained delivery works better than even seeing the patients frequently and injecting with our current biologics. I'm going to call it semi-real world because they're in actually the clinical trials and being followed very closely, and yet the port still outperforms intermittent injections to the best of our ability, which is very telling. And it's an important aspect to analyze. And so I'm convinced sustained delivery in general is going to allow for better outcomes for our patients. And I really look forward to seeing how the PDS system evolves over time in our practice and in the real world, and the potential, as you mentioned, in the pipeline of other sustained delivery approaches. So, Jason, thank you so much for your insights. This has been very valuable. It's an important topic to address. It's an important option for patients and doctors to treat these common conditions. Again, thank you.
Thank you, Carl.